live now. مساء الخير يا جماعة. احنا النهارده بنكلمكم من بلاتفورم جديد. البلاتفورم بتاعنا دلوقتي بقى لايف ستريمينج، وبنستريم على الفيسبوك وعلى اليوتيوب في نفس الوقت لايف ستريمينج. الكومنتس بتاعتكم والاسئله بتاعتكم هتبقى بتتكتب في الكومنتس سواء على اليوتيوب وعلى الفيسبوك، واحنا لو في اي اسئله هنقدر نجاوب عليها، لو في اي كومنتس وي كان هايلايت ات. النهارده معانا الدكتور احمد ناصف، استاذ واستشاري النيورو اوفثالمولوجي. النهارده هيكلمنا على Neuro-Ophthalmology Examination Pupil Testing و Pupil Examination Testing Color Vision Use of Ishihara. النهارده is a very interesting talk ومهمه جدا في الكلينيكال ابلكيشن وفي الامتحان بتاعك، سواء في الاف ار سي اس اللي الدكتور احمد يعني خبير جدا فيه، اكزامينر قديم في الاف ار سي اس جلاسكو، او في الدكتوراه بتاعتك او الماجستير. دكتور احمد احنا بنرحب بحضرتك، اهلا بيك معانا، وممكن حضرتك بقى تعمل شير للسكرين بتاعتك علشان يبدا المحاضره بتاعتك.
Right, and I'm sharing my screen already دلوقتي. Can you see me?
No, you need to share it. أنا ثانية واحدة. أهي تمام كده؟
Okay, ما
دخلنا كده.
Can you see me?
السكرين بتاعتك فول سكرين. اتفضل.
Okay. يعني I'm present دلوقتي.
Yes.
Okay, I just want to thank Dr. Walegendi for his beautiful introduction. Actually, I know that we have several non-Arabic speaking colleagues with us, so we'll try to maintain an all English lecture. Those who have a problem we can discuss any questions in the end. If you want to have it in Arabic, we can discuss in the very end the questions at your request in the Arabic language. So I'm welcoming all our colleagues, and actually. I'm a comprehensive ophthalmologist. I started my training 35 years ago, and I always had an interest in neuro-ophthalmology, and I was very lucky to study at Wills Eye Hospital at more extent with Drs. Sergot and Mark Moster, who were very helpful to me. And I'd like to take a minute here so that these are my contacts. So if anybody has any further need for more information, who has a case, you can send to me on my Facebook and the Neuro-Ophthalmology page or by my WhatsApp account. I'll post the screen later at the end also for anybody who is going to miss this. So what's our aim here today? This will take about an hour. We're going to sit with each other for an hour. There's been an introduction. We're set to talk about the pupil examination workup, color vision. We're going to mention, of course, some important physiological and anatomical basic aspects of it, and how to use the different tests, mainly Ishihara. But is this our main aim? I mean, all this knowledge is actually present in the books. If you go to online, you can find nothing here is of my own thinking. I only gathered the information from many other sources. We have to thank those who produced this type of information for us and made it available. And so the question is, first, where does knowledge come from? It comes from, you can have it from books, of course, you can have it from peers, you can have it from your professors, from your patients. That's where you learn from. Along with all the internet that has made research very easy for us now. But since the knowledge is here, so why are we here together? I mean, you can find out everything you want. I didn't get anything from somewhere private that's not accessible to yourselves. So the point is that I'd like to refer to you to this Bloom's taxonomy, which shows that the basic learning skills, which is remembering and understanding, these are the least important. Or they're very low in this pyramid, And what we need to learn is how to apply, analyze, evaluate, and create solutions for the problems that we see. So, of course, we can't analyze anything or apply any information without having the basic information first. I know that basic sciences like anatomy and physiology pose some difficulty, and some people find them really hard to assimilate, but they are important. And I assure you that if you really try to learn these basic sciences, you'll find that the clinical aspect actually falls in place automatically, and it becomes a simple point of common sense. So what we're going to learn, of course, we're going to mention a lot of knowledge here today, but the whole aim that I want is how to use this knowledge. This is what's really important. And today, that's the main theme that we're going through. So Albert Einstein said education is not learning the facts, but training the mind to think. And this, I think, is the most important, because you'll always have your information in front of you. Now, in thinking about a case, we can get puzzled. What's this? What can this patient have? So the core of our thinking should always be the differential diagnosis. And we'll walk through the differential diagnosis and how to use it. So, of course, first you have to have the basic knowledge for understanding the differential diagnosis. Then you have to have the differential diagnosis in your mind to be able to work through it and solve the problem. Okay, having said this, let's embark on some points of neuro-ophthalmology examination. Now, in the previous lectures, we did mention a few things when we talked about optic neuropathy. The last lecture was about visual fields, which is very important, but let's go through them again. So, neuro-ophthalmology examination, we have the 5 Ps, which is what you see about the patient once he enters your clinic. You can see if he has ptosis. You can see if he has proptosis. You may notice that he has some sort of head tilt or head turn, so this is abnormal head posture. If he has some sort of tropia, ESO or EXO, you can notice that also. And so this is abnormal head posture. And of course, if you come close enough, you may notice problems with the pupil that say they're not the same size or not the same color, etc. The next thing that everybody of us should do, I think we all do it, is check the vision. So when we check the vision, is that enough? I mean, you just sit the patient and tell him what he sees, ask him? No. What the vision that we have to comment on is actually the best corrected vision. This is the most important. And you'll see in a real case scenario how this was so important. Next thing is color vision, which is very important. I check almost every patient that comes to me for his color vision. And it's one of the aspects of knowledge that we're going to speak about today. Of course, there's the brightness of perception, in which you ask the patient if the light intensity that he perceives in one eye is the same as the other, or are they different? Is what one eye says, he'll see that the brightness appears dull. So that's another function of the optic nerve. Of course, the pupils, and we'll talk about it today. Visual fields, we talked about it the last lecture, confrontation, types of perimetry, and so forth. And we're not supposed to omit the basic ocular examination on the slit lamp. Never forget to measure the intraocular pressure. And also, of course, we have to look at the fundus. Mainly, of course, in our interest is the disc and the macula. But anyway, every patient should receive this type of ocular examination that in my clinic, in a neuro-ophthalmology clinic, is added to the basic ocular examination, of course, what is relevant to neuro-ophthalmology. And we will share together today. And also because it was a feedback from one of the colleagues in the last lectures and was asking about the light reflex. So to talk about the light reflex, we have to know the anatomy. it goes without saying that without understanding the anatomy, things become very complicated and very difficult to understand. So this same picture we saw when we spoke about the visual field, but let's remember that the fibers will cross from the optic nerve, and then the nasal fibers will cross to the other side of the optic tract. Temporal will cross here with the same side of the optic tract. And those that are concerned with the light reflex actually will not continue to the thalamus and to the lateral geniculate body, because they're not related to seeing. No, they will turn out in what is called, you'll find it in general books of anatomy, the superior brachium, which sort of climbs upwards and turns very, very close to the brainstem to reach the posterior part of the midbrain. The midbrain, of course, is the uppermost part of the brainstem. And it goes to the superior colliculus, which is the posterior part. So in the midbrain, we have 4 colliculi. We have the superior colliculi above, the inferior colliculi below, the inferior colliculi opposite the 4th nerve nucleus, and the superior colliculus here is opposite the 3rd nucleus. So let's take a look at this schematic drawing on the left side, and we can see that if you simulate this left eye with the light source, so the stimulus will run through the fibers in the optic nerve, and then they will go in both optic tracts, the right and the left, to reach both 3rd nuclei opposite the superior colliculus, and then each and every colliculus will also innervate each of the 2 3rd nerve nuclei, mainly the Edinger-Westphal nucleus, which is responsible for the pupil constriction. So stimulating one eye, if you understand this mechanism, must stimulate the constriction of the other eye. Okay, I think this is very clear and we all know it. So what happens is that the fibers will go through the 3rd nerve and reach into the orbit and relay at the ciliary ganglion, parasympathetic ganglion, across the nerve to inferior oblique, and then reach through the posterior ciliary nerves to reach the pupil constrictor muscle. Right. So what else do we need to know here in the anatomy? Those who attended with us the visual field section will remember that we said, although anatomically we consider the temporal fibers, those that are temporal to the disc, the nasal fibers, those that are nasal to the disc. However, this is not what happens in the crossing or neurologically. Actually, in the visual field, it's all related to the center, to the fovea. So the nasal fibers will actually be those nasal to the fovea. So you will find out that nasal to the fovea, that means the maculopapular bundle, most of it actually is the nasal fiber that will cross to the contralateral side in the optic tract. Okay, just remember this anatomical point. So now let's talk about what happens when we stimulate the eye. So we have this nice diagram here. So now this is the pupil diameter. Let's say it's 5 millimeters in ambient light. This is room light. And then you point a flashlight on the left eye here, like we did here. So what will happen to cause it to constrict it and that of the right eye? And it makes sense, of course, because we can see that it supplies both 3rd nerves equally. Okay, that's fine. If you do the same here, you'll find that also the pupil will constrict. See, this is 5, it becomes 4. In this example, you'll notice that the left eye constriction was actually much stronger than that of the right eye. On examination, in the clinic, sometimes you cannot differentiate between the constriction of one eye and the constriction of the other by just thinking about how this was and comparing them in your mind. So the better way is actually to move the flashlight quickly from one eye to the other and see. Now, in a normal situation, where the constriction is equal in both eyes, where you have a normal optic nerve and optic tract and so forth, you will find that if you move quickly from this to that eye, the pupil should remain constricted as it was. There should be no change because the same amount of light stimulus hasn't changed. But say if this eye has a problem, then the amount of stimulation is less. So actually, the constriction that it is in is much more than it can afford when you give light into it. So when you shift to it, actually, compared to this, it will dilate. And this is what we call a relative defect. Relative means what? Means that the constriction here is present. So we comment on the pupil, we say round, regular, and reactive, okay? So it's reactive. It's not irreactive. But compared to the other one, there's actually a defect, which would not be present if everything was fine. You'd find that they would remain constricted as you go from one to the eye to the other. I hope this point is clear because we'll see it actually in real-time video. So these are the grades. It's not really important. It's an academic thing. And the more important thing is if you do find a relative defect, this means immediately that you have a problem. And we'll talk about what the problems can be. So let's go on to see this video. Okay. And here we go. So this eye is constricting. Okay, when we shift it here, dilated. Again. The left eye is constricted. The right eye dilates. The left eye constricts. The right eye dilates. The left eye is constricting and the right is dilating. So remember that the right eye is actually round regularly active, but its dilatation is much less than the other one because this is the diseased eye. So we call here, it's called a right relative afferent pupillary defect. Okay, so what does that mean when we have this? I want you first, before I go on to that point, is to notice that the movement from one eye to the other was direct. You move directly in a straight line because a straight line is the shortest line between one eye to the other. So you move the pointer, the light from here to here, directly from one to the other. And your source of light has to be perpendicular on the pupils and quite close to the eyes. So you move from here, one, and then directly here, and then back again, two and forth. You don't move behind the nose, down the nose. There's no point in that. You're just delaying. And if you go away, if you're not going in the straight line, what happens is that when you move the light from here, this other pupil will start to dilate back to the ambient light room light. So when you go back to here, if you take too much time, you'll find it as if you're doing a simple light reflex test without being able to compare it to that of the other eye. Why? Because you want to shift the lighter from one to the other while this one is still under the effect of a constricting effect of the first eye. Okay? So we'll take another look. We'll move forwards, okay, now. So if I do get a relative pupillary defect, what does that mean? When do we get it? Of course, any optic neuropathy. It can be a neuritis, inflammation, demyelinating inflammation. It can be a compressive lesion. it can be ischemia, it can be hereditary, whatever. Any neuropathy can cause that. But also, if we remember the anatomy, it can also occur in optic tract lesions. So let's remember here that this is the same picture we saw before, that the fibers of macula actually go here. So if I have a lesion here, it will still cause a defect here. If I have a lesion in this optic nerve, this pupil will not react as strongly as the normal one. And if I have a lesion in the optic tract, also you may find that this pupil will also have a relative defect compared to the other one. In this case, when we have a left relative pupillary defect and a right optic tract lesion, we call it a contralateral afferent pupillary defect, as opposed to the usual relative afferent pupillary defect, which is related to the optic nerve. So this means if I'm suspecting a compressive lesion and I find that there's a problem with the relative defect here, I should ask for an MRI of the optic nerve, and also goes beyond the chiasma to the optic tract, because the lesion can be in the tract. Of course, if you have a central retinal artery occlusion, a total detachment, or an ischemic central retinal vein occlusion, you will also get a relative pupillary defect. I'd like to add something that's maybe is not very familiar, is not popularly known, and this is that in some cases of amblyopia, you may also get a small element of relative defect, of relative afferent pupillary defect. Okay, so now let's move on to some cases. Now this is a real case. So this young lady, she came. Originally, she had a problem. She felt that she had one eye that the pupil wasn't as similar as the other one. Usually when we see such cases, we call it anisocoria. But she was worried. And somehow she got to be diagnosed as an optic neuritis, which was extrapolated into being an MS. And she really became worried. She even got belt steroids, and she went from one doctor to the other. She began to feel that her vision is worsening. And then she came to me. So, as we agreed from the beginning, what's our rationale? Now, when a patient comes, you have to, you listen to the patient very well, but you don't begin from the diagnosis that has been reached by others. You have to reevaluate the case from the start. So what's the first thing we agreed to check on? Vision. And the unaided vision was, as you see, very, very poor. So what's the most common cause of poor vision? Refraction. And lo and behold, I was so surprised to find that she was a myope. Not only that, did she ever wear glasses? No, she never wore glasses. Can you imagine that? She was in her early 20s. So we did a correction. Her vision was fine. So what ended was the matter of the pupils. Now, let us agree that anisocoria is not an indication of optic nerve affection. Because as we saw, that if you have one eye that is fine, it will cause the other eye to constrict with it at the same level, whether it is okay or whether it is has a pathology in the optic nerve or optic tract. And of course, we did the rapid, and there was nothing. She was fine. So the basic complaint that we need to remember here, other than her vision, which turned out to be simply a refractive problem, was that she had a right dilated pupil. That was the problem, that they thought that the right dilated pupil was a problematic eye. So what we need to go through is the differential diagnosis of anisocoria. And that's what I always think that it is the key element to every patient that we see. We have to consider differential diagnosis as we go. So as we know, and this is knowledge, the pupil that is dilated may be the problem. The constricted pupil may be the problem. So how to differentiate which is the pathological one? Simple. Now, a dilated pupil is a pupil that is unable to constrict. So this we'll find out in the light conditions. We find that the good pupil is constricting while the dilating pupil remains dilated. And vice versa. You'll find that the constricted pupil will not dilate properly in the dark. So you know that this is the pupil with a problem. Okay, again. So anisocoria, you have one pupil that seems more dilated than the other, or one that seems more constricted than the other. Which one is the problematic one? To find out this, we need to see if the dilated pupil is able to constrict with light, or the constricted pupil, is it able to dilate in the dark? So if the constricted pupil does not dilate in the dark, then this has a problem, this pupil. If the dilated pupil is not able to constrict, then this is the problematic one. So what are the causes now? And if the dilated pupil does not properly constrict, so it's either due because it had a mydriatic, traumatic mydriasis, tonic, which is Ades tonic pupil, or maybe there's a problem with the third nerve. Now, the constricted pupil, the famous Horner syndrome, which we usually have a lot of other signs to see, maybe the pupil is stuck to the lens, which is posterior synechia, making it unable to move for any reason. Or also, now Ades tonic pupil begins being unable to constrict and then ends up at a later stage being constricted. So it's also one of the differential diagnoses. We must not forget that there are people who have anisocoria physiologically, and it's not a small percentage. In the physiological type, you'll find that both pupils are able to dilate and constrict, but that they are different. So what we need to do is now to do the workup of the differential diagnosis here. So this patient, we found that the right pupil, the dilating pupil, was able to constrict fine. But the pupil that was constricted couldn't dilate. As we agreed, we should do a slit lamp examination, and I was very surprised to find that she has posterior synechia. For some reason, she had posterior synechia. There was no signs of inflammation or anything, but she did have it. So that's why her pupils showed anisocoria. Now, what I want you to remember, her main complaint was poor vision and different pupil size, anisocoria, okay? The dilemma started when she was branded as MS, and from one doctor to the other, they took that she already has a problem being diagnosed by a colleague and so forth. And she was seen by several doctors. Then she felt her vision was worsening because she was told that she would not regain her vision. Made her feel very bad. So always remember to have a positive influence. Not only verify, not only always take the differential diagnosis, always test the best corrected vision, but be a positive, because there are papers that say that by suggestion, you can cause psychosomatic symptoms. And when the doctor says to the patient, you're going to go blind, he's putting such a heavy burden on the patient, and the patient believes him. And you can see from the diagram on your right hand how from stress and personality can cause emotional and other hormonal imbalances, vascular problems, and cause ophthalmological problems. Okay, so just be positive with the patient. All right, so let's move on to further examples. Now, my point here is just to show the examples and we'll not go into a comprehensive discussion about each of the entities. So this is a patient in room light. Of course, you can see that the anisocoria here is quite obvious. And you can see that you have the right pupil appears to be dilated, like the case that we mentioned before, and the left appears to be constricted. So what do we need to do now? We need to check it in bright light, and we need to check it in dim light. Okay, so let's go on and see what's going to happen. So in bright light, we found that the right dilated pupil actually would not constrict. So what does this tell us? It tells us that this is the pathological pupil, because it should constrict in bright light. And let's see in the dark, you'll find that the left pupil actually dilated very nicely and became almost the same size as the other one. So let's go back to our differential. So what did we agree here? We agreed that the dilated pupil is the problematic one because it would not constrict. So we can drop this, we can drop the physiological. And now let's consider pharmacological. Did you put any eye drops in your eyes recently, the last week, last few days? No, she didn't. Is there any history of trauma? We can see that the eye is fine and there's no history of trauma, so we drop that. There's no ptosis, there's no problem with the ocular motility, so we can easily drop the third nerve. And we're left with what is called the tonic Aedis pupil. Now, tonic Aedis pupil is a very nice entity. I encourage you to read about it because it's not that uncommon. Now, there are two tests that we can do that can help us verify the diagnosis. First, you can see that the right pupil is dilated, so ask the patient to converge. So what happened? Well, there is slight constriction of the right eye. Let's check again, see? You can feel here that the right eye constricted a little bit. But we do have another better test. And what's that? We can use pilocarpine in a very diluted dose that would not affect the left pupil. So the concentration that we use is actually 0.125, 1/8. And we did that. And this is how it appears. So this is the room light, and you put the pupil, and you can see how it affected strongly the Aedis pupil, while not affecting in the least the other left pupil. So this is a diagnostic test, and the patient usually comes actually having a problem with accommodation. If they don't have this refractive error, they would notice that they've begun to be blurred for near, because it does affect accommodation also, and near vision for those patients. And there's nothing to do except that you just say that you explain the case to the patient, you explain that there's no problem here. You don't need imaging or anything else. If you want to check if it's Holmes, you can do a knee jerk, and then if it's absent, then you can say, okay, this is a Holmes Aedis pupil. But this is academic. And what you need to do is to put the patient at ease. Make the patient understand the problem. Some cases, I may even formulate the drops for them in this concentration if they can find it, because azotocarpine isn't as easily found as it used to be before all the new anti-glaucoma drops. And to tell them to use it in the morning if they're going out in the sunlight or if they want to read and so forth. But the most important thing is reassure your patient. So this is an Aedis tonic pupil, and this is confirmed. Let's take another example. And so this is, you can see that there's right ptosis. And maybe if you look carefully enough, you can see that the right pupil is a little more constricted than the left one. So at once, what comes to mind? Horner. But first, we have to see, does it dilate in the dark? So let's check. No. So this is in the dark. You can see the left eye dilated very well, and the right pupil is the same. Okay, so we now know that the problem is that this right pupil is not able to dilate, and we have this ptosis, and so most probably this is Horner syndrome. So let's take another example. Now, you can see that in this patient, we have elevated the left lid. And you can see that there's exudaviation of the left eye. And you can also notice that the pupil is dilated here. So this is a form of anisocoria. But here, because the ocular motility is a problem and this is a third nerve, you can see this. If you just leave this, there's a total ptosis if you let the lids go. And what's the most serious thing that we consider here is the MRI, because an aneurysm can be fatal in this condition. So this is an important point to remember. Okay, I think we've covered most of the important aspects of anisocoria. I hope it's very clear. If you have any questions, please write them down. We can go back to them in the end. Now take a deep breath. If you want to get up, you have 10 seconds. Make it 20. Because we're going to begin a very interesting presentation. I hope you'll find it interesting regarding vision. So when I started to prepare this presentation, actually, it's a presentation I gave in the basic skill transfer course for ophthalmologists. And I found that there are aspects of color vision that are really interesting that I was never aware of, and I'd like to share it with you, apart from the basic things that we need to know. So are we all ready? Great. Now, I want you to understand light in the sense that it is simply an electromagnetic radiation. We all know that, but try to give it a minute of thought. So if you have a radio, then you'll be able to pick up the station that you want if it's an AM or FM. If you don't have an FM, you won't be able to pick it up. Same thing, that vision would not exist if we didn't have the photoreceptors. Light would simply be another electromagnetic wave. But we have this photoreceptor, so this electromagnetic wave we began to call light. It became vision. And you can see that the electromagnetic spectrum is quite wide, from very long wavelengths moving down to this very short, very high vibrating short wavelengths. And that our visible spectrum lies within this small part, which is about 400 to 700 nanometers. Now, on the right-hand side here, we have the short wavelength, and on the left side, in this diagram, we have the long wavelengths on our left side. So this is the range of the visible light for humans. Now, ultraviolet light, can people see it? In some cases, actually, it was apparent that when they began first to put an IOL in the eye after cataract surgery, patients began to see blue colors more vividly. And as we will see later in a slide here, that flowers, if you can see ultraviolet light, flowers will take on a different appearance. You'll see different patterns if you can't see ultraviolet. And that was very interesting. But the point was that there are several papers, you can read about them. They showed that actually ultraviolet light decreases the visual acuity. So they suggested that we use ultraviolet filters in IOL to have better and more effective vision. So although they could see the ultraviolet light that could make them see different patterns that were otherwise invisible to them, to humans, but are actually visible to other creatures, as we're going to see, they found that because it decreases visual acuity, it's better that we put an ultraviolet filter in our IOL. Now, This is to show compare the upper, this one is for humans. You can see that the bees and the birds actually can see the ultraviolet light. And on the right side here, for those who like dogs, actually they can't. They are bichromats, dichromats, sorry. They can see a small spectrum, the yellow and the blue. So, but spiders, for instance, actually make special silks that reflect ultraviolet. Why is that? Because the spiders want to catch insects. They don't want the birds to come to not see them and spoil their webs. So knowing this, you think maybe this is an academic thing, but no. Actually, in major cities where they have these high skyscrapers that are all windows, you'll find, especially like a place in New York, a lot of birds bang into the windows and die because they think that they're flying into the sky. They see the reflection of the sky and they get killed. So a German company actually took the idea from the spiders and formed this glass. It's called Arnold Glass. And this is what you see. It looks like a normal glass, but if you look at it with an ultraviolet light, you can see that the birds will see something like a cobweb, and it will help them avoid hitting the windows. I thought that was really brilliant of them. But actually, seeing ultraviolet is very important to many. So you can see butterflies can actually find healthy mates. Birds can tell the male and females apart by seeing ultraviolet. Reindeers can spot their food in lichen and even urine of predators. Now this is the colored photo, the flowers, the black-eyed Susan's flower. The bees see it on the right side. Now us humans would see this, but when they removed the lens at that time and they could see the ultraviolet, this is how they saw. They saw this new pattern that nobody else can see, which is the bullseye design. You can even have something like scorpions that glow under ultraviolet light. Okay, so what we saw was the fun part. Now let's get down to our anatomy and physiology. We all know that the retina we see because the retina has rods and cones, and these are the photoreceptors. We also know that the photoreceptors have a specific anatomy. We also know that we have an outer segment, and this outer segment is actually embedded in the retinal pigment epithelium, and it has the discs. And that the rods have the discs inside within encapsulated in a cell wall, while the cones, the discs are actually outside, and they are also formed from the cell wall. But they're not separate like in the rods. Now, let's go further deeper into this. So this is a cell wall, a membrane. What is it formed of? And also here, the discs are formed actually from parts exactly the same structure as this cell wall. And we'll understand why this is important in a minute. Now, this is from a physiology book. And we all know that the cell wall is formed by a bilipid layer. And this is the phospholipids, and you have the hydrophobic end inside, the hydrophilic end is outside. But what's actually of interest to us is these proteins. They are called integral proteins, transmembrane proteins. Okay, why is that? Because these act as the receptors, and they are very important in changing whatever happens inside the cell. So a hormone can attach to them, and acetylcholine, so forth, and they do their work on this side with the RNA or DNA or whatever. So they can change the cellular function. And this is actually what a photoreceptor is. So a photoreceptor is an integral protein in the cell membrane. And you can see here the rhodopsin, these are the molecules. Okay, these are the actual photoreceptors inside the discs. They are embedded in the cell membrane. Here's the bilipid layer. And the pigment is actually like rhodopsin. And the same thing with the cone pigment. We can see here in the cones, you can see these are also our pigments or as we can see, the iodocin and this. Now, in the cones, we have three types. We have the short wavelength, the middle wavelength, and the long wavelength cones. And each has a specific sensitivity, as we're going to see. The cause that makes them different is that the amino acid, although they appear similar, very similar in structure, yet the difference in amino acids here will cause the chromophore absorption to differ between each one and the other. And this is how it's depicted here. We can see that the peak sensitivity of the small wave with the S cones is quite far from the middle, which is the green, and the red cones, which are quite close to each other. You can see that they're overlapping mostly. Now, the long wavelength cones, you can see here that their peak sensitivity is actually in the yellow-green zone. But they are still called the red cones because they actually can be stimulated by the long wavelengths, which is the red color. This is the same graph, but you can see here how close the red and green cones are to each other in their wavelength sensitivity peaks. Now keep this in mind because this has a bearing on color vision. Now, we understood this by cones, but actually in coding now to reach the brain, if a red cone is stimulated more strongly, your brain will see it as red light. But suppose that the red and the green cones are equally stimulated, then what you see is yellow. So this is how it acts. It acts as a mixture of how strongly which one is stimulated more than the other. We remember this from when we talked about the visual field. We can see that now this is the cone mosaic in the central 1 degree. Now the foveola, the ambo is actually in the center here, and you can see here that there is a blue area that is devoid. This is the area that's devoid of blue cones. You can see the cones, blue cones dispersed here. And actually, we do have a small center of 0.35 or 0.34 degrees, which is cone-free in this middle. So we do have a small blue scotoma here at the ambo, the center of the foveola. But most of the retina, throughout the retina, the red and green or long and middle wave cones are the most ones that are distributed. So this is just to remember that the foveola is 1.5 degrees. So the ambo, which will be 0.35, right in the middle, is where we have the blue cone. We don't have blue cones and blue cone scotoma or blue scotoma in the center. So the cones become stimulated, and then comes the ganglion cells. The ganglion cells, you have parvocellular, which can transmit red and green, and then you have the blue and white, which is called the coniocellular system, and also these play a role in how the brain perceives color. So you have the red and green pathway, and you have the blue and yellow. Actually, the coniocellular system takes the blue and yellow with it. All right. Now, a few small definitions. So when you say anomaly, that means that you have just a weakness. Anopia means there's nothing, there's total absence. So when I say protonormally, so protonormally will mean prot will indicate the red color, so it means weakness of the red color. If I say Deuteronop, Deuteronop means absence of the green pigment. If I say Protaneup, opia means absence. Okay. Now Tritone, which is quite rare, actually means absence of the blue pigment. So any patient, any person can be monochromatic, has only one type of cones, may have two types of cones, or maybe the normal trichromat has all three types of cones. Now the dichromats and monochromats, these are the ones with color deficiencies. Now color deficiency or color blindness may be hereditary or may be acquired, of course. So we can remember that the congenital is more in the, type is more in the males. Doesn't mean that it doesn't happen in the females. It does, but very rarely. and most females are carriers. And the proton types, whether opia or omalia, protonomally, these are the more common. The Tritone, the blue, is least common. Now take a look at this. So this is how the colors are seen by a normal person. As we said, the red and green cones have a very close sensitivity spectrum. And you remember the wave that how the red is in the yellow, green, while the middle wavelength is in the green. And you can see that both of them actually have almost the same perception of the different colors. They're very similar to each other. The Tritone is quite different, actually. You can see the difference here. So any patient who sees this or this can be either red defective or green defective. So he can be a Protonormally or a Deuteronomally or a Protanopia or Deuteronopia, okay, in these cases. And so if you're going to eat some peas with carrots, a Deuteronomist person or a Protonomist person will see it like this. He won't be able to see the orange color. Everything will look the same to him. Now there's the acquired type. In the acquired type, we do notice that there are cases where more you can see the loss of the blue color. But generally speaking, in optic neuropathy, you can find that there's absence. They can see the red quite well. Also in chondrodystrophies, you can see in some retinal lesions, like retinitis pigmentosa, diabetic retinopathy, macular edema, they will lose the good perception of the blue color. So we can have color blindness can be acquired or congenital. In looking at colors, now the type of color, the wavelength is the hue. So this is red, green. This depends on the hue. Now the saturation means how rich the color is. So if it's not rich, then it's like pale, like you've added white to it. And then we have the aspect of brightness. Now certain colors give more energy and they appear more bright. And in the color testing, so actually some people with congenital color defects are able to differentiate colors according to the brightness in nature. So in the testing, they were very careful to keep the brightness similar from one hue to the other. Now we'll shift to which type of test do we have for color vision. So there's something called City University test. I know it's not very familiar with us, and we are more familiar with what is known as the Ishihara isochromatic plates. What I'd like you to know is that the Ishihara tests only for red and green. It can't test for blue. City University test actually tests for blue also. And we're going to see an example of the City University test at the end of this lecture. Now, interpretation of Ishihara test. Usually, let's say the concise version of 14 plates. We usually base them on the first 11 slides. Now, if the patient is able to see 11, 10 out of 11, he's fine. He's normal. If he's able to see 7 out of 11 only, then no, this is abnormal. So what about in the middle? Okay, so 8, 9, this means that you need to recheck the patient again. Now, let's go on to discuss Ishihara. I think most of us have seen these plates, but I think very few looked up to there's a pamphlet inside the book to tell you how to use the book. And I think the big mistake is that we omit reading this. And actually the information here, I just simply got it from the pamphlet with the book. Now, we have what we call, there are actually 5 types of charts. They're not all alike. We have an introductory chart, which you see here, which is the 12. And of course, with each number, you have its counterpart for the illiterate person who doesn't know how to read numbers. So he just follows along this pathway, or the snake as we call it, from one point to the other. So, and this is present in all the charts, all the time. So introductory means this is, everyone should see this. If he doesn't see this one, this means there's a problem with vision. You can't continue the test. Okay, suppose you can't see it. How can you test color vision? Actually simple. You just get the red filters that you have in your lens box, trial lens box, and use it. You put the torch behind it and ask the patient, what color does he see? He can tell you. People who have a problem, like in the acquired optic neuropathy cases, will tell me that instead of seeing red, for instance, they are actually seeing yellow. But this is a way to test color vision using the red and green filters that you have in your box, and instead of the Ishihara. Okay, so the patient was able to see this introductory chart, which means that he should be able, if he was normal, to see the rest. So what are the rest? We'll go through them quickly and then see the examples of them. We have what's called transformation, and we have what's called vanishing, we have what's called hidden, and then in the end we have a group that shouldn't be used unless you do have a defect. It's called classification. Okay, so let's focus on these three. Now we understood the introductory chart. Let's skip this for now. Now the vanishing chart is one that the normal will see the number, but the one who has a color deficiency won't be able to see it. To him, the color has vanished, the number has vanished. Contrary to that is the hidden digits. These are the places that you as a normal person won't be able to see any number. But if you do have a color defect, you'll be able to see the number. So to you, the normal, it is hidden. Okay? Now let's go on to the transformation. The transformation charts, you find here, this is present with all the Ishihara books. And they show you that you have the first 10 here. These are the transformation charts. Now, the number of the plate, you can see, the number, you will see 8, for instance, but actually the person with red-green deficiency will see 3. You will see 57, but the person with deficiency will see 35, and so forth until number 9 here. The person you will see 74 as a normal, while this with a red-green deficiency will see 21. So it's called transformation. So the normal will see one number, while the red-green defective person will see a different number. So let's go on to check them. Now these are photos from a real book. And you can see here, these are the transformation from the first 9, 2, 3, 4, 5, 6, 7, 8, 9. So there are 8 charts. And you can see here that the 8 appears as 3, the 57 appears as 35, the 29 appears as 70, and you can see here the 8 is seen as 3 and the 6 appears as 5. Okay? Of course, you have the counterparts that are the snakes or the paths, and you'll find that a normal person will be able to move along this path, but an abnormal one with red-green deficiency will find himself moving on another path, completely different from this one. And these are the rest of the transformation pages up to page 9. And you can see here, for instance, this is 74. You can see a 74 here if you have proper color vision. If you have a problem, then you'll see 21. It's a transformation. Here, if you see the 3, it's actually seen as 5. And its counterpart, as we explained before, with the illiterate charts. So these are the transformation charts, okay? So we're supposed to take the first 4, and then we take one of these. We'll explain this in the end. I mean, how many, should you go through all these charts? No, you don't need to. You just need a few. Now we come to the vanishing plates. All those who have a good color vision will see all the numbers here. 7, 5, 16, 46, 97, and so forth. But those with the red-green deficiency will see nothing. So to them, these are the vanishing plates. And you have the illiterate exactly the same. So a normal person will be able to move his finger along this line, an abnormal and a red-green defective person won't be able to see anything here. So it's called the vanishing plates. And then you find these hidden digits. Actually, I never use these unless in persons that are, say they want to work in the military force or as pilots, and they really are very ambitious and very passionate about it, and then they have a discolor problem, so they fail the test once or twice, and then they come to me. So I always begin with the hidden digits here, because they really, what they do is they try to memorize the plates. And I begin with this because they will be able to see the numbers here. So once he's able to see these numbers, he's thinking that this is what you should see. I understand immediately that he has a color defect, and because these are the hidden digits that he should not see. But when you're examining a patient, you don't really need to use these ones. Okay, so we established that the patient has a red-green deficiency. Now, okay, so what you need to do here, you use the classification to know if he's a proton, if he has a red problem, or a deuton, which he has a green problem. I mean, he has loss of the middle wavelength, or the loss of the green pigment, or loss of the red pigment. So what you do is you show him these are the charts that we call classification. So let's take this one. So this is a 26. Now, if he sees only the 6, means that he has a problem with the red cones. He can't see the 2. So this is a proton. Sometimes they can see the 2 very weakly. So he's a mild proton, okay? If he sees the 6, or the 2, or the 5 here, or the 6 here, then he's a deuton. If he can see the 9 or the 3, the red numbers, then if he can see them a little, he's not really sure about it, but he says, yes, I think maybe this is so and so, but he's very sure of the 2, then he's a deuton, he's a mild one. If he can't see the red numbers, then he is a total strong deuton. So these charts needn't be used unless you have established that this patient has a red-green deficiency, okay? Right, so, and these of course are the illiterate plates, just to remind you that a person should move from one X to the other. Preferably his finger shouldn't be blocking. So if he's moving his right hand, it should be like this. If he's moving his left hand, it should be like this. And this is a suggestion from experience. So now that we understood the test, how do we use it? Can you use it in an ordinary yellow light? No, it has to be daylight. You should hold the plate away by 70 to 75 centimeters, and it should project at right angles to the line of vision. Now, you have to maintain a time limit. So what I do is I show him a page and I count 1001, 1002, 1003, and I shift. I give the patient only 3 seconds to answer it. Now, you don't really need to use all the numbers, all the plates. So of course you use the introductory plate, and then you lose the first 4, if you remember. They are the transformation plates, and you use one of the transformation plates of the other 4, which means 5 transformation plates. And then you use one number from the vanishing plates, and from the first group, and one from the, you use actually 2 from the vanishing plates, one from the first group and one from the second. So if you remember, the first group would be the ones that have the this red background. So you can see, you choose one with the red background, you choose one with the green background, okay? To make a sort of a mixture of them. All right. And this is what you need. So you, all in all, you need about 7 or 8 charts. And if you do find, I don't use the hidden. I don't use the hidden. You don't need it. But of course, you can use it if you feel that the patient, you're not really sure that the patient is really seeing it. So if you use one of the hidden charts and he's able to see the number which he shouldn't be able to see, then you have to revise all the tests again, because this means that this patient actually was very clever and he beat the test somehow by memorizing the numbers or in another way. Now, let us move to the City University test. Now, the City University test, actually, as you can see, it has a different way.
Device connected.
Now, what you have is that you have one color in the middle, and then surrounding 4 colors, okay? So you have 4 colors here. Now, what you do is you ask your patient, now this is an introductory chart here. You ask the patient, which one of these 4 is most similar in color to the one in the center? It's obvious that it is this one on the left side. You shouldn't touch the chart, by the way. And it's the same thing. It has to be daylight. It has to be at a reading distance, say 70 centimeters. And he will tell you that it's this one. So let's take another one, like this one. The same question. Now, compare this center to the other 4 here, and choose one of the 4 that is more closest to the color of the center. You'll notice here that maybe the right one is the closest, but it isn't similar. It's different, but closer. And I'll show you a chart of a patient that I saw. So this is the chart they gave you with it. And they tell you which direction should we see, the left one, the right one, the top one, or the bottom one. And they give you how, if a proton, what a proton would see, what a deuteron would see, what a tritone would see. And I did have a patient, actually. And as you can see, I marked it, he turned all to be deuteron. He came at this one. First he said the left, and then he changed his mind, actually, and said it was the right one. So just to give you an idea about the tests that are present in the market, and easy to use, actually. This is the City University test. Now, I finished my presentation, and we'll take a minute and see all your questions. This is my contacts. If you need it, please copy what you like. And please feel free to contact me with any of your questions or suggestions. They are most welcome. And thank you very much.
Okay, so now we can take questions. So people can type their questions in the comments section, either on Facebook Live or on YouTube Live. I'm not getting any questions yet. Is everything clear? So everybody's satisfied and happy? Dr. Ahmed, do you see the comment on the screen?
I'm looking for them, actually. I'm not seeing them right now. Okay. Okay, I'm seeing one comment only.
Yes, and then
okay, I'm getting one comment at a time.
Yes, well, on the screen, I'm seeing the comments.
Okay, is there a way to see them all?
If you go on Facebook or YouTube, I'm showing them all one by one.
Okay, somebody's saying if you please comment on proper method of pupil examination. Okay, I'm not sure what this means because this was half the lecture, but let's go through with it quickly. So the first thing you need to do is to check for anisocoria. And you do that by asking the patient first to look far away, and then you put the torch, your light source, beneath the eyes. You don't want to stimulate the reflexes. You put them beneath the eyes to check and see if the pupil sizes are equal or unequal. The second thing is you ask the patient to look far away. Again, so ask the patient to look far away, and then you check each eye for the light reflex. So you shine a light into one eye, watch the reflex, and then you shine the light in the other eye, and document the reflex. What you need to notice is it round? Is it regular? Is it reactive? And we call it this RRR. So these are the things that you need to ask: round, regular, reactive. Then comes the second point. We need to ask ourselves, okay, so it's reactive, but is there a relative defect between one eye and the other? So this is where we do the swinging flashlight test, which we showed in the video. Now, the swinging flashlight test, you ask the patient to look very far away because you don't want the accommodation to interfere. And then you move the light. You put the light directly in front, I mean, maybe 2 centimeters away from the eye, and you shine the light inside the eye, and then you move very rapidly. You count 3 seconds, 1001, 1002, 1003, and you move very quickly to the other eye, exactly in front of the pupil, keeping your torch or your light source perpendicular to the pupil. And then you notice if the constriction remains or it dilates, and you go back and forth 2 or 3 times, because you may start with the affected eye. So when the affected eye, you put the light, and then you find the pupil constricting. And then you move to the other eye very quickly. You shift in a straight line from one eye to the other above the nose, please. Nobody goes below the nose or below the chin or below the belt. You have to shift from one eye to the other directly. And you may notice that the other eye is actually constricting more. So you go back quickly to the right eye that you began with, you may find it dilating. And in this dilatation, this is what we call a relative afferent pupillary defect. Once you document a relative pupillary defect in one eye, then you know that you have a problem either in the optic nerve of the same side or in the optic tract of the contralateral side. And if the pupils are fine, reactive, and you do have an isochoria, then you go through the differential diagnosis that we spoke about. I hope this answers your question, Amira Lutfi.
Can you please repost the hidden color?
Okay, so in the color test, the hidden figures are the ones that are hidden. Let me go back. Let me share the screen and show it to you, okay?
Okay.
Okay, share screen. Okay. Can you see the screen?
No, you didn't share the screen. Share the screen first.
Okay, I thought I did. Right, okay, share. Okay, can you see it now?
Yes.
Right, so let's go back. So now these are the transformation plates where you see one color, you see one number, and the patient sees another number. The vanishing plates is that you see a number. What does the patient see? Nothing. The patient doesn't see anything in the vanishing type. Now, the hidden digit is hidden for the doctor, okay? So it's hidden from the doctor. The doctor himself or the normal person doesn't see anything. It's hidden from him, okay? So the hidden digits, I don't remember, the question was about vanishing or hidden, so I'll speak about both. The hidden digit is the place that you don't see any numbers. But if you have a red-green deficiency, you'll be able to see the numbers there. Okay?
If you have a patient with
you test color vision, yes. You test color vision, Dr. Azza Sha'lan. Yes, you test color vision as we discussed. And the patient can't see the plates, then you do it with a color filter. And that's what I do almost always. I put a red filter, shine the light, and ask the patient, what color do you see? He may say, I'm seeing green. He may say, I'm seeing yellow. He may say, I'm seeing white. He may say, I'm seeing red. And I use also the green filter also at all the same. I don't trust now. Contrast sensitivity is a way of testing also, of course, vision, but we don't need it in neuro-ophthalmology. It's more of academic, and those who use it are mainly those who deal with low visual aids. So you have to understand what contrast sensitivity is. You'll find that in contrast sensitivity, so the Snellen chart that we see is the 100% contrast, white and black. Okay, but if you have a white background, and then the target is say not black but gray. Now, as a normal person, you can see it. It's low contrast, but you can make it out. Now, a patient who has a neurological problem, or optic nerve problem, will find it very difficult to discern this target. He can't see it because the contrast is low. That's what's meant by decreased contrast sensitivity, and we didn't mention it because we don't use it. Okay, why a patient complains from
red
color defect?
Red color defect.
Okay, red, okay, from red color defect while all cone and rod passes through the optic nerve. Okay, because this will take us back, Dr. Ahmed, actually to anatomy. So the cones and rods are present in the retina. And the ganglion cell head is actually the ganglion cell layer. Now the axons of this neuron moves from the retina down from the optic, down with the optic nerve, back crossing the chiasma, the nasal fibers crossing the chiasma, to the optic tract, all the way to the lateral geniculate body, and this is one neuron, right? Okay. So now the ganglion cells, this ganglion cell transmits all the information that comes from the cones and from the rods. Now, if you have the ganglion cell layer abolished and you have excellent rods and cones, nothing will reach the brain. Why? Because the ganglion cell is the head of the whole axon that transmits the impulse back to the brain. So when you say a neuropathy, an optic neuropathy, it means that this axon is defective. It does not transmit the information. So if you take, say, for instance, that you're on the phone, you're talking to someone. Now, the rods and cones are you speaking. And then you have the connection cut. You continue speaking, but your voice is not being transmitted. So when you have an optic neuropathy, the cones and rods won't be able to transmit the impulse that they transmit from the ganglion cells. I hope I answered you, Ahmad Yahya Jabri.
Okay, thank you, an amazing lecture.
Okay, effect of optic neuritis in color vision and most plate affected in Ishihara. Actually, our colleague Fahd al-Nasr, actually, it's very variable from one patient to the other. So I do find most of the cases are the red affected more than the green. And but when I do the Ishihara, if the patient is able to see, I count how many out of 8 plates the patient is able to see. So some people, they see 7. At some stage, he can see only 2 plates, but when the patient gets better, he can see 5 plates and so forth until he gets all 8. But it's not, the whole point of using the Ishihara here is to detect if there is color vision, red-green deficiency, and the extent of it. So the more severe, the less number of charts the patient will be able to identify. Okay, light near dissociation. Well, it's beyond our lecture here. So we'll keep it for another lecture, okay? It's not on our topic today. Yes, of course. So what you can notice in Ishihara, so Karim Amin is asking, is Ishihara good in subtle optic nerve pathology? Yes. So what you'll notice is that, and this I didn't mention actually, so thank you, Karim, for this question. You can notice that the patient can go through the charts very quickly with one eye. So you give him, you say this 5, this 23, this is, and so forth, 8, and he go through it very briskly. And then the other eye, he'll labor. He'll say, okay, I think this is, and he'll wait a second or two and give you a number. Okay, maybe he'll get all of them correctly, maybe. But most probably, if he has a subtle pathology, he'll usually get one number, not the other. But on the assumption that he gets all the numbers correctly, you'll find that there's a difference in the speed between each eye. One is seeing all the charts easily, one is seeing them with great difficulty, and the patient himself will tell you, I'm not comfortable with this. I'm not able to see them as good as the other eye. No, this is beyond our scope here. Traumatic mydriasis, this is, it's not what our subject today, Asma.
Dr. Ahmed, I think it's
Why a neuropathy patient complaining, sorry? Why a neuropathy patient complaining from red color deficit, a red color, while 3 types of cones passing through the optic nerve? It is the most, well, it's not necessarily the red color only. You can find also the green, okay? Because these are the most fibers that are there. And remember that these are the tests that we use. I mean, in Ishihara, it only tests for red and green. But red, you find red is more affected mostly. But I do have cases that are unable to see neither the red nor the green. And I'd like you to remember that the blue, can we return to the question, please, Dr. Ware?
Yes.
I want you to remember that the cones, it's not the cones that are relaying the information. Remember this. It is the ganglion cells. You have to remember that the ganglion cells are relaying the information that they already work up. They have a certain, it has to pass through the amacrine and the bipolar cells, and they modulate the impulse before the ganglion cell relays it. So it's a complicated process. It's not the cones here, it's the ganglion cells. Thank you, Dr. Well.
Okay.
Okay, Dr. Mata El-Marani, what is the newest modality for management of color blindness? I assume you're talking about the hereditary, because if you're talking about the acquired color blindness, then the only way that you can treat it is by treating the cause. Now, there's no treatment for congenital color blindness, but there are certain types of glasses that can help people see color better. Please, Dr. Ahmed Ismail, please, if there's clinical application for Ishihara test on neuro-ophthalmology cases and another presentation for discussion.
He wants a lecture about the clinical application of Ishihara.
So this is a question like application of slit lamp in diagnosis. So my point is that Ishihara use it to detect color vision, okay? That's the only function of it. Now, if you detect there's a color vision deficit, then you have to ask yourself, why is this person in one eye having a color defect? So it's not only the color, it's about that having a deficiency, having a defective color vision, and acquired, I'm talking about acquired cases, of course, indicates a problem. And the problem is what we should put our focus on, okay? So there's no other clinical application except to detect if there's a color defect or not. Okay, Kansky show figures like 360 clock hours for color tests with scintillizing zigzag around for each specific color. Well, I really, I'm not sure. I don't remember seeing this in Kansky. I'm not sure what you're talking about, Dr. Hind. Maybe you can send it to me on the WhatsApp and we can talk about it more extensively.
Okay.
What about D15 color? No, okay. So D15 color test, of course you can use it, but you won't find it. You won't find it in the clinics. So this is present in certain academic institutes for Ashraf Numan. Thank you, Amir. I have no experience with the Enchroma glasses. It is said that it helps those with color vision, but I have no experience with them. For Mustafa Bakri. Okay. Any more questions? Thank you very much, everyone. Vanishing test is a confirmatory test.
We answered it, yes. We answered that question, right?
Vanishing test, yes. You can use it. I use it as a confirmatory test. When a patient, as I told you, when a patient I feel is trying to pass this test, you know, and he's done a lot of trouble, so I sort of trick him into it. So that's when I use that. I feel that this is the main function for it. Do we need to comment about consensual right reflex during examination of the patient, and do we need to check near reflex during examination of the pupil? Right. So, now I'd like to take you back to the first point that we discussed, that what's this all about? It's about diagnosing the patient, right? Okay. So in an exam, actually, the examiner would like to see you also be looking at the consensual light reflex. But to be quite honest, it doesn't add to my information if I'm doing a relative affluent swinging flashlight test to detect a relative pupillary defect. To me, that is the most important. But the point in doing the consensual light reflex is that you are showing that you understand that when you light, stimulate one eye with light, then you'll expect the other eye to also constrict. But you will never know, is it constricting in the same amount or not, until you do the swinging flashlight test. To what extent does red-green color deficit affect driving? Well, if they're going to do it correctly, I think it's been a long time since I wrote a certificate, because now they do it. They're doing it there in the where they give the licenses. But I remember that the patient should be able to differentiate colors. To me, I think that differentiating colors for driving, it doesn't need an Ishihara. You need that if he sees a red light to know that this is red, if he sees a green light to know this is green. But what the government does, I have no idea, Asma.
I don't think it's a critical thing, because red light is and green light is the lower one, and the yellow one is the middle one. So actually, يعني, I don't think it's a.
They still test for it, على فكرة.
Okay.
It's compulsory to write in the ophthalmology examination certificate whether he's able to see or not to see the lights. Yeah. Oh, that's a wonderful question. Thank you, Khulud. Ishihara test should be done uniocularly? Yes. And if you're looking for a neuro-ophthalmological examination, it has to be done uniocularly, because I'm comparing what one eye is seeing as opposed to the other eye. So if I'm doing, I do both eyes when, you know, you're testing for people who come to asking to work, and you have to see if they can see color vision. But if you're doing a neuro-ophthalmological examination, of course, it's exactly like you're testing visual acuity. Visual acuity, you have to test each eye on its own, correct? And also here, you have to test color vision, each eye on its own. Thank you, Khulud. Thank you. So Jihad seems to have missed the part about the optic tract. Now, Yeah, I'd like you to remember how the fibers move from the optic nerve. Now, they remove backwards in the optic nerve, correct? And then they cross over to the other optic tract. So if we're talking about, say, the left eye, so the fibers in the left eye move backwards and then cross to the right optic tract, correct? From left optic nerve, I'm talking about the nasal fibers. Now, as we mentioned this in the visual field, now the maculopapular fibers, most of them cross to the other side. Now, if the optic tract of the right optic tract is being compressed, it can affect the pupillary fibers of the left eye. You understand? So where's the lesion? It's on the right optic tract, from where the left nasal fibers crossed of the left eye. So if I have a lesion in the right optic tract and it happened to press on the pupillary fibers, it will cause a relative defect of the left eye. But where is the lesion? It's not on the left optic nerve, it's in the right optic tract. So that is when we call it a reverse or contralateral, actually it's a contralateral relative defect, okay? So you cannot know it.
I think she's asking about the reverse relative acting pupillary defect, which is we use it in third nerve or in opposite pupil cornea. I mean, it's the reverse testing of the relative acting pupillary defect.
I have no idea about that, because in the third nerve you don't have a reverse rapid. In the third nerve you have a pupil that's not reacting. Yes. Remember, it's an efferent defect, not an afferent one.
Yes, but if you also have an optic nerve defect in the same eye, if you have an eye that the pupil is absolutely not responding or you don't see it, you have an optic nerve atrophy in this eye, you confirm the optic atrophy by reverse testing of the relative acting pupillary defect. So you shine the light on the eye with the fixed pupil, and then when you go back to the sound eye, you find it constricting.
Okay, so let me just adjust your example. No. Okay, I get your point. So suppose that I have one eye that has posterior cynic.
Exactly.
Okay, so it has posterior cynic and not optic atrophy, because optic atrophy will cause an amaurotic pupil.
Okay.
Now, okay, so now if suppose I'm moving, let's say this is the left eye that I cannot see the pupil reaction, okay? So what happens is that, now let's say that the left eye is the eye that has a good optic nerve and should have a good pupillary reflex. So now I'm shining my light in the right eye and I'm seeing it constricting. I'm moving to the left eye, which I cannot see a reaction in it. And then I'm moving back to the right eye. Now, if I'm moving back to the right eye and I'm finding it dilating, then I know that this eye has a defect in it. Now, this pupil is a relative defect because it should have remained constricted as I shifted quickly back to it from the left eye. Maybe this is what you mean by the reverse. I'm not sure. But you can tell us what you meant by your question, Jihad Musa.
Thank you for the effort. More thanks to the professor. I will examine the pupil in a straight way.
Okay, so we get this a lot. So even Kansky and all those who work with the strabismus patient, they know that light is not an accommodating target. And actually, if you're being examined and you use light for a patient, for a child, say, to measure the strabismus, you will be reprimanded because you should use an accommodating reflex. Now, in Kansky, even the old version, Dr. Wayne, you will find that accommodation is actually 2 stages. So the first stage of accommodation is the one that is a gross type. Even a blind person will accommodate with this type. Why? Because he's thinking that he's looking at his hand first, something close. So you'll have the 3 things converge, the pupil will constrict, and the ciliary muscles will contract. And then you have the fine accommodation, which depends on vision. Now, this is the second part. So it's a sort of fine adjustment. Now, light mathematically equals an accommodating distance of infinity. Try it yourself, Karim. Now, look into the light and see if you can focus on any point. It's infinity. There's no point to focus on. So actually, the most important thing is that you want the patient, you can't see anything when you're looking into light, but you want to abolish the first part of the accommodation reflex, which happens even in the blind. And this is where your demand of the patient, you ask him, please look far away. You have to tell the patient, look far away. This is the first part. And when you tell him to look far away, then you do your testing. Okay, you don't ask the patient to look into the light. You ask the patient to look into the far distance, and then you do your examination. So that's and by the way, you're not supposed to be standing in front of the patient. Another good point, Karim. You're supposed to be standing by the side of the patient for that specific reason as to allow the patient to look further at distance. And then you do your pupil testing. You can't, of course, Abdul. You can't. You can't do a rapid test, and you can't check the pupils with the pupils dilated. Of course not. And that's why in my clinic at the hospital, all the residents, all the young doctors know that they never prepare a patient and give dilating drops before I see the patient, because I have to check the pupils. Right. So it is said that the patient should see about 624, 618. Yes. But what it's very easy to do for Dr. Bahga Abdelhamid. Shufi, what you do is that you show the patient the standard chart, the 12. Okay? And ask can the patient see? And he should be wearing, if he needs reading glasses, he should be wearing the reading glasses, by the way. So if the patient says he can see the 12, proceed. If you can see the standard chart, it's not important what the patient sees for far vision. I check with the standard chart. Okay, you can see the 12. If you have good color vision, you can see all the rest of the charts. If you can't see the 12, I just close the book. Then you can't use it. But I don't stop short at the far vision, okay? I depend always on the standard chart, which has the number 12 on it.
Okay, I think this was the last question. We don't have any more questions coming in.
Okay, good. Without you, this wouldn't have been made to be so beautifully executed.
Thank you very much, Dr. Ahmed. It's an amazing presentation and a lovely lecture. And I hope to see you again soon. And thank you, everybody, for joining us.
Thank you. Shukran. Yeah. Have a good day.
You too.